Vacation plans, long commute, weekend at the cabin. Wherever you end up this summer, the Connector Idaho Daily News helps keep you connected to Idaho, even while you're away. Get the top local stories every weekday morning in just a few minutes. That's the Connector Idaho Daily News. Listen on your podcast app.
More Idaho Matters now from the studios of Boise State Public Radio News. I'm Gemma Gaudette. Here in Idaho, 14 out of our state's 44 counties are considered maternity care deserts. So that means expectant moms in these communities do not have a place where they can receive local care. As a result, they often have to commute, sometimes driving more than an hour to get to the closest hospital. And for some patients, the challenge doesn't end there. When the U.S. Supreme Court reversed Roe v. Wade with the Dobbs decision in 2022, Idaho's abortion ban took effect, creating new concerns for doctors treating complicated pregnancies. Now, in the wake of this, our state lost more than 30% of OBGYNs practicing obstetrics. That's according to a 2025 study, making it even more difficult for patients to receive maternal health care. So joining us now are Kayla Smith. She's a patient that lives in Nampa who was impacted by Idaho's abortion ban. Dr. Jessica Evans-Wall, an emergency medicine physician practicing in Boise, and Dr. Caitlin Gustafson, a family medicine physician in McCall, who is the board president of the Idaho Coalition for Safe Healthcare. And I want to welcome all of you to the program today. Thank you so much for taking time for us.
Great to be here.
Excited to be here.
And Kayla, I'd like to start the conversation with you. And folks, this could be a difficult topic. We are going to be talking about loss. So Kayla, take us back to 2022. What do you remember about that moment that you learned that there was a problem with your pregnancy?
Yeah. So this was my second pregnancy. My first pregnancy was not uncomplicated. I had preeclampsia with severe features. I was very, very sick. I actually ended up having an emergency C-section at 33 weeks. My oldest daughter is almost 6 in a couple of weeks, and she's doing great. So we knew we wanted to grow our family. And sorry, this is my youngest daughter. You probably heard her.
It is it's totally fine.
But yeah, we knew we wanted to grow our family. And so I got pregnant for a second time and everything seemed to go as planned. The only thing we were worried about, obviously, is preeclampsia again. And so at my routine anatomy scan that happens around 18 to 20 weeks, we found out that our son, who we named Brooks, had several fatal fetal anomalies. And so at that time, we saw maternal fetal medicine, and we also saw a pediatric cardiologist. And essentially, we're told that there was nothing that they could do, that this was not an operable condition. The worst that they had seen, and also just the constellation of findings with Brooks's heart defect, were just not something they had ever seen before. So with that, my MFM provider basically was like, I'm really sorry, but there's nothing we can do for you in the state of Idaho any longer. And with that, we had to travel to Washington so that I could receive abortion care.
Kayla, take us back to that. And by the way, if you're just joining us, that's Kayla's youngest daughter with us today as well. So Kayla, I can't imagine what that must have been like. First off, to know that this pregnancy was not viable, that your baby had such fatal anomalies. On top of that, you're then told you can't get the care that you need in Idaho. So walk us through what that was like to have to go out of state to get this health care that you needed.
It was devastating. Also to understand that how privileged we were that we were able to access this care, because that is not something that's accessible to all women or people who need it. We actually had to take a $16,000 loan out to be able to do this. So again, it is not falling on us that it was very privileged of us to be able to do this. I had an induction of labor. I was around 21 weeks because we wanted to meet our son. And so with that comes a bigger financial burden as well. And I also had a previous C-section, which created some other issues of having a normal like B&E and things like that. Also, I still could have developed preeclampsia. So it was just it was like insult to injury, right? Not something that needed to happen. I should have been able to get care from my providers that I had already had rapport with and who knew me and knew my history. But instead, I had to put on my logistical cap and not really be able to grieve the loss of my very wanted child. To, travel 8 hours with my then at the time 3-year-old, and go through 12 hours of labor to deliver my son in an unfamiliar place, and then also have to figure out what to do after that. So what that meant, like, contacting a funeral home, the cost of getting, cremation, all of those things. And then also I had to travel back 2 weeks later to then pick up my son's remains. So a lot of travel and a lot of logistical things. And I felt like I didn't have time to really breathe.
Yeah. Dr. Gustafson, Kayla, first off, thank you for sharing that with us. Dr. Gustafson, as I mentioned, you're a family physician. You practice in McCall. What does Kayla's story tell you about access and maternal health care in the state of Idaho currently?
Yeah, thanks, Gemma. Obviously, these tragedies of our patients they're so hard to hear, and they're far too many. I think it's not lost on anyone in your audience that even before abortion bans in Idaho, we had a real crisis of providing care and having the resources and the providers available. Idaho is one of the lowest healthcare professional states in the nation. When I look at, Kayla's example is really in the larger context. The personal part is so important and so crucial for us to hear those stories. The larger context is that it takes a lot. I'm a rural family medicine obstetrical provider. We know we're in a really rural state. The needs in our urban communities are very important as well. But what I feel like I can speak to from personal experience is what it takes to have a quality and safety at the forefront for rural maternity health care in our state. And at the end of the day, we all want the same thing. We want healthy moms. We want access to care, and it takes several building blocks to do that. You need the facilities, you need the healthcare providers, and you need the patients to be able to access that care. And those issues are compounded, particularly the patient access, payment and reimbursement, all of those things in the patient area are compounded in the rural context for sure. When it comes to laws like this, what you're really affecting is that healthcare professional pipeline, the ability for us to recruit and retain the providers that we need to provide the safe healthcare that we all want to provide in the state. I know so many healthcare providers feeling right now that just these risks, these laws that come in our way that create risk of criminal prosecution get in the way of the safe standard of care that we want to provide for our patients.
And Dr. Evans-Wall, you work in emergency medicine in Boise, and I am sure you have had many times when a pregnant patient has come into the ER and there is a serious complication. What can happen if treatment is delayed when there is, even in Kayla's case, like preeclampsia, because that can be fatal for the mom if it is not caught and treated early, which usually means you have to, in Kayla's case, like have a preterm birth to save mom and baby.
Correct. Yes. I'm so happy to be here and get to talk a little bit more about the emergency perspective. And I do want to highlight that most of the time, these serious complications during pregnancy are very rare. And the worst case scenario for a serious complication during pregnancy would be death of both the mother and loss of the pregnancy. I also just want to reiterate that anytime we're talking about care for a pregnant patient, the thing that's best for the pregnant patient is best for the pregnancy. So whatever we do to take care of mom is going to be the best possible thing that in the long run we're taking care of either that baby or future fertility if that's desired for that patient. The other thing that I would love to take the opportunity to bring up is that even here in Boise, we're an urban center. We have relatively a lot of providers per capita in comparison to the rural areas in the state. And we are still seeing that it is hard for people to get in for routine care. So let alone the emergencies that we see related to pregnancy, I also see folks who have healthy pregnancies not being able to get in for normal follow-ups or normal ultrasounds at their normal timeline to be able to find things that could be either dangerous for baby or for mom. And so that's something that even here, I see that people are getting delayed initial visits. And we are using our amazing family medicine providers as well as our OB providers that we still have here. And it is still a struggle to get folks in for routine care. And we're feeling that in the emergency department because folks are coming in to see us with stuff that otherwise they might be able to see a routine outpatient provider, but they can't.
Dr. Gustafson, when a pregnant patient develops a serious complication, and I'm just talking about making the pregnancy high risk, right? So maybe they need extra care. How much does living hours away from a specialist or a hospital with more resources impact the care that can be provided? I mean, you live in McCall. I am sure you've seen this before.
Yeah, it's such a great question, Gemma, because this really gets at, the other elements of what it takes to keep, the healthcare providers that are needed by a community there in the community. One of the critical elements to that system of care, this isn't about any one thing. It's all of these systems that have to come together to provide that overall safe system of maternity care. And it really relies on, in my case, being able to get that MFM on the phone, to co-manage patients, to know that I can get timely transport to Boise where there's a NICU. When we're able to do that, we can safely deliver in McCall. But we put a lot around that, a lot of protocols, a lot of practicing. We're a low volume but high acuity center, in which it goes from low risk to high risk obstetrics in a matter of minutes that can happen. And so it's those systems in place, the ability that within your center and your hospital, each community hospital is going to have a different way that they approach this, but they need to be able to have the tools to do it, to be staffed 24/7, including surgical services. Or in the case of a birthing center, we love our midwife partners who give great maternity care, but they too need to be able to access, surgical services in a timely manner. And so that's all part of that system, and the referral system and the co-management. We do a lot of that with both our OBGYNs as family docs, as well as our maternal fetal medicine docs. And that's what makes myself and others able to stay in these rural communities and continue to provide the care and feel really good about the quality and safety of care that we're providing, even though we've got the challenge of that distance to the larger hospitals.
So Kayla, you actually became a plaintiff in a court case, Atkins versus the state of Idaho. What did you hope would change when you decided to challenge Idaho's abortion law?
I think ultimately we were just trying to clear up the laws for our providers, realizing that they're clear as mud, right? There was a lot of confusion around what a provider could or couldn't do for women who needed support during pregnancy, whether that was a situation like my own or a termination earlier in pregnancy for, fetal anomalies. And so in that lawsuit that we had, I think the goal was just for us to help clear up those laws, make it so that providers felt safer to be able to provide the care that women deserve in the state of Idaho.
So, Kayla, what were you feeling when you heard about last Friday's federal ruling that Idaho's abortion ban must allow healthcare abortion when they are necessary to preserve a pregnant patient's health?
It's an exciting thing, right? To see them the laws cleared up even more. However, it still left questions for me, because obviously one of the things that they did rule on was that it didn't change anything for women who wanted an abortion for fetal anomalies, right? And so for me, I mean, I would have to defer to the physicians. Like, is it clear in my situation? Like, is it still a situation where they don't know how sick I have to be before they could intervene? Like, we could also say, yes, my mental health was at risk as well. During that time, it was probably one of the darkest times of my life, knowing that I could still feel my son, but he wasn't going to be able to survive outside of my womb. However, I don't know if, that even though the laws are cleared up even more now, if that would help me in my situation.
Dr. Gustafson, in your opinion as a physician, from your perspective, does this ruling from last week give doctors a clearer understanding or maybe a clearer standard for when you can intervene? Or are there still situations, as Kayla just described, where there is doubt about what the law allows?
Well, first of all, I would just, applaud Kayla and the other Adkins plaintiffs, everyone, Dr. Saib, everyone who stood up to say what we all know, which is that abortion bans cause direct patient harm. They chill the care away from standard urgent treatment in complex pregnancy complications. It remains to be seen. The courts are a long and difficult battle, and it's a winding trail. But at the end of the day, what we really understand, and what my organization and what so many more physicians and community members, with us understand, is that these complex pregnancy decisions belong in the exam room, and that's what we want. They belong with the standard of care and what we know that keeps patients safe, and we just have to work hard to get back to that place where we're preserving that healthcare professional relationship with their patients, because otherwise the care becomes too complicated and our patients are at risk.
Dr. Evans-Wall, with this new ruling, what does that mean in like an emergency room situation? Because can you walk us through what can happen when doctors have had to wait for a patient's condition to become life-threatening rather than being able to treat that immediately?
Sure. Thanks so much. I think that for us, this ruling has potential to be helpful if the appeal doesn't go through and we actually are able to kind of follow through with this in the long run. I think that the frustrating thing for us in the emergency department is that our job is to take care of emergencies immediately, even if we have limited data available. So we use all of the information that we have from seeing a patient in that moment. It's really hard for us to necessarily project, will they get more sick quickly? Will they get more sick slowly? Will they be stable long enough for us to be able to transfer the patient? I'd like to echo the difficulty I think that Dr. Gustafson was pointing out, and say that some of the uncertainty creeps into the emergency department, even in those acute settings of how can we actually care for this patient in this moment legally? And so oftentimes we end up having delays, not only because we have to say, hey, we can't say there's an imminent life threat right now, but there could be in a couple of hours. So that could lead to delay in care. But it can also lead to delay in care when we have physician partners who are unsure about where the law stands in this given month because things have been shifting over the last few years. And so then we need to get legal involved, and then we we have all of this other muddying of the decision making when the decision making should just be between the healthcare provider and the patient. And oftentimes we're having to pull in other folks that should not necessarily need to be in the exam room, like legal counsel, to be able to help kind of untangle the details of where we stand at any given moment based on court cases and legislation.
Dr. Gustafson, I have just under 2 minutes left, and I want to get to this question, and that is the fact that we are now waiting to see what could happen with potential cuts to Medicaid. What could reduced Medicaid funding mean for patients who rely on these services, but in particular, what it does in rural areas in our state?
Yeah, thanks, Gemma. This gets to, where I started, which is that other incredibly important element to safe maternity care, and particularly rural maternity care, along with, as I mentioned, having the right facilities, having professionals who can and will stay here despite the challenges. We have to support patients to enable them to access the care, and Medicaid cuts are devastating. We know that the great majority in some areas of our state of the patients accessing maternity care depend on Medicaid. We also have a fair number of patients who can't access any payer source. And so it's become down to individual communities to provide a safety net for these patients. And we need to get back to a place where our state can really provide for our patients so that they can access the care that's there. And that's the only way we're going to move forward to have the safe system of care that we all want.
I want to thank all of you so much for your time today. Such an important conversation to be having. We've been speaking with Kayla Smith, Dr. Jessica Evans-Wall, and Dr. Caitlin Gustafson about healthcare in Idaho and in the impacts of our abortion laws and potential loss to Medicaid. You've been listening to the Idaho Matters podcast from Boise State Public Radio. To stay in touch, you can find quick Idaho daily news every morning when you subscribe to the Connector podcast. Just by listening, you're helping to support public radio right here in Idaho. And I want to say a big thank you for that.